patients will present with lower extremity symptoms, but they'll have little aspects that might be consistent with a musculoskeletal issue or a neurological issue. It won't quite fit perfectly with claudication. About 15% of patients will give you that perfect history for intermittent claudication, and then 2% of patients will present with what we call chronic limb-threatening ischemia or critical limb ischemia. The important thing to recognize about peripheral artery disease is that patients may start in one category and rapidly shift to another. So they could be asymptomatic, and they don't necessarily need to go to claudication as their next step. They could go from asymptomatic to rest pain or tissue loss. And so that's why it's so important to treat these patients aggressively once you've diagnosed peripheral artery disease, because you never know what the next year, the next week, the next month will bring. Looking at the natural history, if you take a patient with claudication, there are really two groups of concerns that you have. You have the 5-year limb morbidity and then 5-year cardiovascular morbidity and mortality. For 5-year limb morbidity, if you have patients with claudication, about 70 to 80% of those patients will continue to have claudication. 10 to 20% of those patients will go on to develop worsening claudication, and 1 to 2% of those patients will go on to chronic limb-threatening ischemia. The problem is we don't know which ones are going to progress. Hopefully in the future we might have biomarkers or some other way of telling that. But equally important in a claudicant is the 5-year cardiovascular morbidity and mortality. Of patients with claudication, 20% in the next 5 years will have an MI or a stroke, and 15 to 30% of those patients will die. So it is important to identify peripheral artery disease, not just because you want to make them walk further, but because you want to do everything you can to prevent cardiovascular events. In the clinical evaluation, we have patients, we can use their symptoms to at least get an understanding of what level of arterial occlusive disease they might have. So if they have buttock and hip claudication, then typically we expect to find some evidence of aortoiliac disease. If it's thigh, it'll typically be aortoiliac or common femoral. Once we get into the upper calf, that's typically superficial femoral. And you can see the pattern here. The symptoms are always going to be one notch less than where we expect the occlusion. So lower third of the calf is probably going to be behind the knee at the popliteal artery. And then patients can get foot claudication. Oftentimes they're misdiagnosed and sent to a podiatrist. Luckily, podiatrists know about PAD and can right the ship. But if patients have foot claudication, it's typically due to small vessel infrapopliteal disease. So now we'll get into one of these cases. So this is a 67-year-old man with diabetes, prior smoking, hypertension, high cholesterol, all the good risk factors, presenting with calf cramping when walking. First noted the cramping when climbing hills on the golf course, but now kind of feeling it even when walking on level ground. The discomfort gets better with rest consistently, and his symptoms seem to be a bit worse on the left. Patient has a blood pressure of 172/82 in the right arm and 166/80 in the left, so hypertensive. Femoral pulses are 2+ without bruits, and popliteal pulses are a little diminished, 1+ bilaterally. Distal pulses are 1+ at the DP and PT bilaterally. And so in the office, we do an ankle brachial index, and we'll talk a little bit more about that. But it's 1.1 on the right and 1.0 on the left. Not bad, right? So here's our first question for you. In a patient with exertional limb symptoms but normal resting ABIs, which is the best initial diagnostic study? Is it straight to an invasive angiogram, CT angiogram, MR angiogram, an exercise ABI, or vascular PET? Go ahead and log in your votes. Well, based on this voting, you may not need a lecture from me, but we'll see how we go along here. But I think most of you have have voted there, and the winner was exercise ABIs, and that's correct. Remember, these symptoms are exertional. So a rest ABI, while it might help us to diagnose peripheral artery disease, even if it's negative, it doesn't tell us that their symptoms aren't due to claudication in peripheral artery disease. So we do the exercise ABIs, and at rest, like I said, they were normal. But immediately post-exercise, there's an abrupt drop in the right to 0.7 and on the left to 0.6. And 5 minutes after exercise and recovery, they come back to normal. So this patient has intermittent claudication, which by definition is reproducible discomfort in a defined muscle group provoked by exercise and relieved with rest. And I find this table really helpful, and we're going to spend some time going through it because we get patients coming to see us with leg symptoms, oftentimes with exertion, and this kind of a stepwise approach can help us to clue into what the right answer might be. So intermittent claudicants typically have a location of pain that's in the buttock, thigh, calf. The quality of the symptoms, crampy, achy, fatigue. The key part is the onset should be after the same degree of exercise and quick relief with rest. If someone tells you, I get calf cramping when I go out to get the mail, but going upstairs, 3 and 4 flights is no problem, that should make you wonder about whether this is arterial in nature. It needs to be reproducible, so they can't walk and get claudication going to the mailbox one day and feel fine the next day. It should be very consistent. Spinal stenosis, similar, hip, buttocks, thigh, tends to follow more of a dermatomal distribution. They may have some weakness. They may feel like their legs giving out. Pain is there. The onset will be with walking or standing and relieved with position change. So what I tend to ask my patients is, when you have your leg pain, if you stop in place and stand, does it get better? Because if it does, that fits a little bit more with arterial occlusive disease and a little less with a sort of spinal stenosis or neurogenic syndrome. If they have to change position like sitting, that should clue you into a potential neurological etiology. Typically, they have a history of back problems, but not always. Venous claudication we see less frequently, but this is important to know about. So typically it's whole leg, congestion, tightness, heaviness. The onset's with walking, but slow relief with rest. They oftentimes have to put their legs up. It can be half an hour before they feel like their leg is less tight. They will oftentimes have a history of DVT, or they'll have edema on exam, lots of varicose veins, venous insufficiency. So ankle brachial index, this is calculated by dividing each of the systolic pressures in the ankle, the DP and the PT, by the highest brachial pressure. Very good for identifying patients with peripheral artery disease. These are great numbers, 95% sensitive, 99% specific. On top of that, an abnormal ABI automatically identifies a patient population at high risk for cardiovascular events. Now, there are some variations in the calculation of the ABIs. What I told you is the usual ABI. So the usual ABI is done to see if there's perfusion-related disease. So we want to know, is there decreased blood flow to the lower extremity that's causing pain? So we take that highest ankle pressure and divide it by the highest arm pressure. With the knowledge that you have anterior and posterior circulations. You have the dorsalis pedis circulation and the posterior tibial circulation. So the limb, even if one side, if the anterior circulation is poor, the posterior may compensate and you may have a normal ABI. If you want to know if they have cardiovascular disease, atherosclerotic cardiovascular disease, or peripheral artery disease, then it's the lowest ankle pressure over the highest arm, because you just want to know, what's the worst that it is? And you look at your DP, you look at your PT. If any of those are abnormal in the ABI, you know they have atherosclerosis. And that has implications for how we treat them. Looking at ABI, sort of and correlating that to severity, first thing I'll note is no matter what, if the ABI is abnormal, it's associated with a future risk of heart attack and stroke. 0.8 to 1, patients typically don't have a lot of symptoms. 0.4 or 0.5 to 8, we're looking at claudication, maybe atypical limb discomfort. Once you drop below 0.4 or 0.5, that's where you'll see evidence of critical or chronic limb-threatening ischemia. It might be rest pain, it might be tissue loss, an ulceration, those sorts of things. Identifying PAD is important because, like I said, once you know they have atherosclerosis in the lower extremity, they're higher risk. Automatically, they get net reclassified to a higher risk population. So these data here, looking at patients who've had MI or stroke or PAD and no MI or stroke, if you have PAD and a history of MI and stroke, you have multivascular disease or polyvascular disease, the highest risk you could possibly get, looking at a course of almost three years. What we consider normal for the ABIs changed a little bit. So it used to be 0.9, then it's 1. It's kind of stuck at 1. But this study in JAMA, now almost 20 years ago, was pretty groundbreaking for a couple of reasons. 3 big myths that are broken up by this study. First, we used to think a high ABI was great. No matter how high it was, as long as it wasn't less than 0.9, we're in great shape. Well, it turns out patients that have high ABIs, greater than 1.4, they typically have vascular calcification that stents the artery open when you inflate the cuff. So when you